So our next speaker is Andrew Goodner. Andrew is a PA at Piedmont Hospital in critical care, and he's going to talk to us about cardiogenic shock, the rest of the story. Andrew?
Hi, thank you very much for having me. I am super honored to be here, and I suppose I need this clicker to get through. I have one of my attending cardiologists sitting next to me, so he can call me out on anything I say that's incorrect. But I just want to share with you our experience in the CCU, and I wanted to do it from the perspective of trying to touch on everyone who touches a cardiogenic shock patient, from initial encounters with EMS, RNs, ER, and then the bedside management with APPs, RNs, and then physicians who are non-intensivists. So that's my home. I do have a disclosure that I'm a speaker for Abiomed, but there are no conflicts in this talk. I won't be discussing any of their products. These are my central points. I want everyone to agree upon at least the early recognition of cardiogenic shock is a necessity for successful management of cardiogenic shock. The early transfer to a team that has experience with cardiogenic shock at a shock center or a shock hub, whatever name we like, essential for survival. Early utilization of invasive hemodynamics, people who are familiar with Swan-Ganz catheters, early utilization of mechanical circulatory support that is characterized to that patient's ventricular predominance and oxygenation needs, and then a comprehensive head-to-toe look at a cardiogenic shock patient's management. So it's a lot to go through. I'm going to move quickly. I am only really going to be discussing the phenotypes of cardiogenic shock related to acute MI and decompensated heart failure. We do have two other groups that are a part of this, but they warrant a different discussion altogether. So our post-surgical and then our other arrhythmogenic and so on, obstructive. So this is going to be a case that I present. This is very similar to what we see in real time. A 64-year-old female with a known past medical history of an adriamycin-induced non-ischemic cardiomyopathy, diagnosed a while ago, compliant with GDMT meds. She's on home milrinone. She's a stage D heart failure patient who presents to a clinic with a presentation that is not necessarily in the front of your mind as a classic heart failure presentation. EMS may see this patient at their home. They may call 911 and say, "My wife is confused, she's not talking right," or "I feel just rotten, I haven't been able to eat for several days." This isn't your classic short of breath, lower extremity edema, orthopnea patient. This is very, very different. So you put this person in a truck or you look at them in the ER, and your initial exam is not terribly compelling for what you classically think of as shock. You have a blood pressure that is normal. You have a heart rate that is normal. These are not quite normal, though. The mean arterial pressure is low. The heart rate is relatively high. No one should really have a resting heart rate of 95 all the time, especially not a heart failure patient. They've got an elevated respiratory rate, even though they're satting 100%. So anyone who is seeing a patient with this sort of clinical picture should begin to think, based on their history and their exam, this may be shock. They have the physical exam findings consistent with it. This is a shock patient, and this is not your classic hypotensive needing pressors. This is a patient for whom there are lots of things that are contributing to their shock, but this is that congestive phenotype. So shortness of breath and pulmonary edema on a chest x-ray are not always the things you're going to see to declare a patient a shock patient. You're going to see a much more, on this list, my favorite two things that I look for are capillary refill and JVP. If I have big JVD and sluggish capillary refill, I'm very worried about that patient. Classic phenotypes are broken down in this 4-square box. Many of us have seen this. This is the cold, dry, cold, wet, warm, dry heart failure patient, shock patient. But the evolution of understanding shock, I think, has become more broad and demonstrating that shock exists on a spectrum of severity. And that spectrum can be recognized as a shock patient who is not necessarily presenting as cold and wet, or worse, cold and dry. Let's get through there. This is your clinical picture of an acute MI shock. They are very easy to spot. They are not neurohormonally adapted to shock. So they're sweaty, they're mottled, they feel terrible, they look terrible. They're a dumpster fire of a patient. They're very difficult to manage, but they're easy to spot. We recognize shock occurs across this sky staging pathway. Now, we look at sky staging as a means of recognizing a shock patient before they are so obviously shocked that anyone can get it. My particular interest in this pathway is the shock B, the before they need pressors, the before they need mechanical support, the shock patient that when EMS or ER is bringing to the CICU, that everyone says, oh, they're just a little wet, their maybe blood pressure's a little low, we're going to start them on some Levophed. I'm always very worried about that patient in the initial assessment, because if we can move fast on this stage B, we can save this patient quickly. EMS can recognize this often based on those simple physical exam findings, also based on that clinical history. This is a known stage D, milrinone-dependent heart failure patient. So they go to the hospital, we get some labs, their lactate is normal, so maybe they're not hypoperfused, but we have elevated creatinine, elevated LFTs. We have evidence of end-organ hypoperfusion and dysfunction, and again, the physical exam is supportive of shock. So this is shock. This is stage B, maybe even stage C shock. Moving into that, she's increased on her milrinone, and aggressive diuresis is pursued, but we don't get a tremendous urine output response. We see that our efforts are not yielding the kinds of responses that we need. So this is what RN reporting at bedside is very helpful for. This patient may be admitted to the hospital as a heart failure patient, and when they have inadequate urine output, we may not know until 24 hours later when the patient is rerounded on, whereas an astute RN paying attention to this patient can call in the middle of the night to the CICU team and say, hey, this patient has not responded to the escalation in therapy. They are not peeing the way they should. They're not perfusing. So what's missing from this picture is a Swan-Ganz catheter, advanced invasive hemodynamics, either via the right heart catheter or Swan-Ganz catheter. And that is where the value of a CICU patient management comes in. We do see that with utilization of PA catheters, we have a better means of making decisions about this patient's use of mechanical circulatory support or escalation of vasoactive agents. So as this data body grows, we continue to see publications that are showing that with the use of invasive hemodynamic monitoring, we can make decisions about durable mechanical circulatory support as well. So we can start to talk about destination for these patients. In an acute myocardiogenic shock patient, we look at two potential outcomes, which is left ventricular heart recovery or ventricular recovery, and then a destination to a durable device. In our long-term stage D heart failure patients, we're thinking more about either decongestion or transplant or VAD. So we see a decrease in mortality with the use of invasive hemodynamic monitoring. This is why it's important to get patients to CICUs, CCUs, where people are familiar with the use of PA catheters. At our institution, we put them in at bedside. At some institutions, it is done in the cath lab as a right heart catheterization. But nonetheless, all staff who are encountering this patient need to be familiar with the use of that PA catheter, why it needs to be there, how to obtain numbers, how do you look at it exactly as it's supposed to be used. That's a whole talk unto itself. I'm not going to go on about that, but I am going to talk about what that hemodynamic assessment looks like. This is sort of your basic look at cardiac output, cardiac index. There's multiple ways of assessing that. Looking at SVO2, I try to avoid SCVO2s when I can. Looking at right atrial pressure, looking at pulmonary capillary wedge pressure, pulmonary mean pressures, SVR, PVR, but these other two features of hemodynamic assessments are things that are incorporated into a lot of the cardiogenic shock algorithms that have kind of emerged and have been validated in their data as improving outcomes. So cardiac power output is a means by which to point towards mortality in a patient cohort of less than 0.6. So 0.6 is your cutoff for that. If you hit that number, you start to think you're at the inflection point of mortality in these patients without more advanced levels of support. That's the key. They need more support. And that is a clinical picture that is painted by all things other considered. The lactate coming down, the patient's warm, they're peeing a ton. Maybe that CPO of 0.59 doesn't mean anything to me. But that's clinical assessment, and that's bedside assessment that all comers, RTs, nurses, APPs, they all need to be able to report this stuff back. And then this pulmonary artery pulsatility index is a calculation off of your SWAN that gives us some information about right heart performance. So without dwelling on that too much, it's important for everyone to know what they are in the management of these patients. So this patient gets a hemodynamic assessment. They have a CPO that's theoretically an acceptable one, but they have a cardiac index that is not. They have an elevated CVP. They have a PAPI that's okay. So this is left ventricular predominance. Their O2 sat we know was okay. What do we see? What do? We continue to manage this patient. We escalate as we deem necessary. So this is the midnight call that all of our physicians get. Somebody is calling and saying, I don't know what to do. My numbers are mixed. What is what is the information that they need to be conveying to you at 2:00 in the morning while you're out of a reverie? And that is things like, how does the patient look clinically? Do they look warm? Are they mentating appropriately? Do they have brisk capillary refill? Have they put out 3 liters of urine in the last 6 hours? That is a patient for whom I'm not that concerned of that cardiac index of 1.7. They are evidencing clinical perfusion. However, if we continue down that pathway, if we say they're sluggish capillary refill, we're on max milrinone, they've only peed a liter, this is a mechanical circulatory support patient. So going back to I'm trying to avoid being redundant. We've talked about cardiogenic shock teams, but I think that involving all aspects of a patient's care, from not just the CICU at Piedmont Atlanta Hospital, but every ICU or every ER at every hospital within every hospital system, is important. And giving access to a shock team by which any person can communicate to the experts in cardiogenic shock at any time along that continuum of care is going to yield better outcomes. We're going to see patients have improved outcomes, better utilization of mechanical circulatory support by opening up the door to communication, by allowing shock teams to be on call for people at outside facilities at all levels of patient care. So including EMS, ER, RNs, APPs, multi-system collaboration, using standardized approaches to care. We get many patients sent to our center with mechanical support devices who have no hemodynamic assessment. They have no SWAN. They might not have even gotten a right heart catheterization. And that's difficult for us to make decisions with, and we have to go advance that. I would hate for a patient to wait 2 days for a bed at my hospital and not have any changes to their management done when someone could have picked up a phone and called us or called our shock team to say, hey, while we wait for this patient to be transferred to you, what can we do next to advance their care? How can we escalate their care? And a lot of that comes from nursing staff saying, hey, you know what? Their lactic was 8 yesterday and we haven't checked one in 24 hours, right? So we need to go through this process of making sure those patients are taken care of over a timely fashion. Shock teams, again, this is slide number 2 on the same topic, but better utilization of pulmonary catheters, better utilization, even though lower utilization of mechanical circulatory support, but yielding better outcomes, and that is the goal. And shock teams are available or should be available for anyone to be a part of so that they can communicate with us at the hub from the outside. These treatment objectives in our ICU really at the top of this chart are what I want this slide to be about. We are recognizing that incorporation of CPO and PAPI are important. Lactate is very important. I have a slide, I'll talk about that. The time from initial diagnosis of cardiogenic shock to mechanical circulatory support is very important. But what we want to see at the top is liberation from vasoactive agents. When we get calls from someone saying, hey, we're up on our Levophed and what do you want for a second pressor, that's not achieving our goals. We very much need to accelerate that patient to a higher level of support. Early escalation to MCS or higher level of MCS. If they're on Impella, go to ECMO. If they're on ECMO, go to 2 ECMOs. Just kidding. We don't do that. And then LV or biventricular recovery. We don't focus in our CICU on trying to pick the right inotrope. We look at the hemodynamic profile of a patient, say for instance, if they need some chronotropy or if they are a little vasoplegic and they're a little hypotensive and have an AKI, we may be more favorable to epi or dobutamine or milrinone. There's kind of an equal choice in it. They don't yield a significant improvement in mortality the same way that mechanical circulatory support is being shown to do so. And when we also see a patient on initial assessment, we want to know not just the initial lactate, but the trend of lactate clearance. The rate of clearance over time in a short period of time has an implication on mortality. Again, the people who are getting the calls from the lab are the ones who are going to let me or the attending physicians know this information to make decisions. So across the pathways, everyone should be looking at lactate, not just at time of assessment, but the next one. I do them serially 4. Q8 is, I guess, fine, but in this study, you want to look at a rapid rate of clearance. In this particular study, we saw a 13.5-hour cutoff in time to escalation for MCS for refractory shock. So we were talking about patients who are on a single vasoactive agent that were not getting better. They're escalated to mechanical circulatory support, and the survivor curve starts at about 13 hours. So a 12-hour shift makes a little more sense for us, but we know that that's our window of time to intervene on one of these patients. We cannot wait for day 2 of rerounding after morning rounds to make a decision about MCS. So it's around the clock, hour by hour by hour, we're managing these patients. So in this slide, you'll see that time is one of the key essential ingredients to looking at managing a cardiogenic shock patient, moving quickly. It's kind of a weird time slide there, but 0 to 90 minutes, 0 to 120 minutes is where we're talking about hemodynamic assessment, ventricular predominance recognition, and recognizing that they're hypoperfused even at 2 hours means it's time to move up, upgrade this patient to mechanical circulatory support. As you see here, there are a variety of different tools. That's usually not our choice to make, but it is our job to impart the knowledge to the people making that choice, whether or not this patient is O2 dependent, whether or not this patient is going to need an oxygenator, whether or not this patient has biventricular failure, if they have RV dysfunction or something to that degree. So once we get on mechanical support, we continue to look at the same numbers, invasive hemodynamics, to escalate and de-escalate. So that indwelling swan is very important for a lot of these patients. In VA ECMO, it yields a little bit different numbers, so we can use other tools like echocardiography and real-time VTIs, all that sort of stuff. But we still continue to look at physical exam. A patient who is still sluggish capillary refill, not clearing a lactate, those are patients who need to be recognized early at the bedside, brought to the attention of the ECMO physician, and escalated on their support. As we stabilize these patients, we start to declare their outcome, their destination, so to speak. So are they transplant, VAD, or do we need to start talking palliation? And palliative care or palliative inotropes are certainly in consideration for these patients once they're stabilized. Mechanical circulatory support is fraught with trouble. They bleed, they stroke, they get infected, and people at the bedside are what prevent that from happening. It looks like, it looks like the picture on this did not cross over. Sorry, folks. But the image on this is to show that if you anticipate the problems with the device well in advance, if you know to be looking for hemostasis at groin access sites, if you know to be assessing for a hematoma's growth or something to that effect, a patient with new low back pain, do they have a retroperitoneal bleed? Are we seeing new fevers on a patient who's on a CRRT circuit who should be otherwise normothermic? These are things that we can look out for at the bedside in routine hour by hour management of these patients to yield better outcomes. So this is a lot of stuff to try to remember. Atul Gawande, a physician at Brigham and Women's Hospital, wrote a great book called The Checklist Manifesto. I think everyone should read it, about creating checklists. And I'm not going to belabor what's on these checklists. These are my checklists from my epic dot phrases that I use to remind myself of all the things I just presented to you. So this is every cardiogenic shock patient that I get. I have this dot phrase that comes up when I hit dot Drew shock. And it gives me, I can delete what I want, I can take back on, I can keep things over a course of time. I can see what assessments need to be done or have not been done for this patient, to just remind myself, where are we in the continuum of this patient's care for their level of shock? So that's my shock checklist. This is my hemodynamics checklist. I include the equations just in case, as well as some cutoff numbers. You can see where I've marked badness on some of that stuff. It talks to me, it speaks to me, that word matters. So I know that when I start hitting those crossovers that I need to be calling this guy right here and saying, hey, we're dealing with badness up here. Lactic acid checklist is short, but the numbers are weird. So again, more badness numbers. I just need to be able to remind myself, what is the threshold by which to start thinking of escalation? And then my MCS daily checklist, regardless of the device, each device has some specific management requirements, but I look at these patients through every day. I will dot phrase this, and I will sometimes just delete the whole dot phrase after I've looked at it, but to remind myself not to miss, what are the Impella waveforms, or what are the flows on the ECMO circuit? Where is the balloon pump augmenting? Is it in the right position? How are the limbs looking? How are both limbs looking? Is the patient well supported? And then this is that final statement about the management of cardiac ICU patients in totality, which is they need comprehensive and full assessment and management from head to toe, often a multidisciplinary approach involving dietary, physical therapy, occupational therapy, sometimes case management, social work, chaplains, that we have to be in totality seeing these patients from every vantage point that we can to ensure that there's a good outcome. It's not just, okay, the hemodynamics are good, we're done. It's, are they able to move their limbs? Are they talking? Are they depressed? We deal with a lot of depressed patients who are sitting around in bed for extended periods of time, waiting for a heart, waiting for a transplant, waiting for an LVAD. So we try to look at these patients in totality. And then, of course, ICU delirium prevention is super important. So again, you can see these are dot phrases and checklists that I use to manage a patient. This is why a patient is best served by a cardiac ICU and by a team that has experience in dealing with all these different things. Sorry, y'all, I talk with my hands, so I'm just up here conducting your orchestra. So last case study, this one's gonna be a little bit easier and I'll try to move quickly. We have kind of your classic hyperlipidemic, hypertensive, doesn't go to the doctor, doesn't listen to his wife kind of husband, who is having chest pain for many, many hours, goes to the ER, he's found to have an anterior STEMI, he goes to the cath lab, and our heroic cath lab rescues this patient. They do absolutely fine. During the cath, well, maybe his blood pressure fell a little during balloon inflation, he's got a little bit of levofed, he gets his PCI, he's got TIMI-3 flow down the vessel, he comes up to the CCU, and the first question out of my mouth to everybody is, what was his EDP? I always want to know, what was his EDP? Where are we at in that intraventricular pressure system that his now freshly injured heart, though revascularized, is working against? So comes up to the unit, little bit of levofed. 5 hours later, somebody comes and finds me and said, hey, we're approaching maximum levofed dosing. What do you want for your second pressor? And that's not the question I want to hear. I need to know that they know that escalation of vasoactive agents is a bad idea for this patient. That patient, as soon as they begin to escalate, within the hour or two, I call this guy back over and I say, hey, I know you just got home and just got back in bed and are really cozy, but you got to come back in. He's going to need more support than this. So management success keys, right? Using an algorithmic approach to inform your treatment of a patient like this at all levels of their care, RN, RT, PT, I don't care, all of you. Using early hemodynamic assessments, using invasive hemodynamic assessments early, advocating for early assessment in these patients there are questions about whether or not they're doing well. Escalating to mechanical circulatory support as soon as there is an indication to do so, not delaying that care until shift change or tomorrow morning in the cath lab or whatever the case may be. It needs to be done now to get that patient to survive. Minimizing or weaning off all of their vasoactive agents, not escalating them to maintain mean arterial pressures. When you can't achieve that goal, that's escalation to a higher level of mechanical circulatory support. Comprehensive head-to-toe management involving multidisciplinary teams, consulting out to all levels of care for an ICU patient, and getting a patient to an ICU that can offer all those levels of care. Do not fear making a checklist. It's going to make your life way easier. So that's it. Any questions?
That was a great overview. Questions?
All right. please feel free to reach out to me, any of you, if you want.
I don't have a question.
Yes,
I'm
please.
just going to tell you that was an awesome overview of cardiogenic shock in a very short period of time. So
I tried my best.
congratulations. It really was. It was good. I just had a couple of comments, actually. You mentioned that, that one of the first things you ask is what was the EDP. So for anyone who doesn't know what the EDP is, so the left ventricular end diastolic pressure is your pressure inside your ventricle when you're measuring it invasively in the cath lab. So it gives us an estimate of what the coronary perfusion pressure is going to be. It gives us kind of an overview of how sick the patient is. So anything over 15 is abnormal. When it's over 25, we get really worried. But the other thing, and one thing I wanted to mention is, I think taking care of a cardiogenic shock patient without a PA catheter it should never happen.
Should never happen.
And unfortunately, it still happens a lot. We see it happen not uncommonly. I'm sure it happens all over the state on a regular basis. But I think if as a nurse or as a cath lab tech or cath lab nurse, if you see somebody with cardiogenic shock on the table, if you're adding a pressor or you're putting an inotrope on, you should make the suggestion, speak up, say, hey, why don't we put a PA catheter in? Or if you're in the nurse in the CCU and the patient comes back with an Impella in and they don't have a PA catheter, where's my PA catheter?
Yes.
I think everybody needs to advocate for that because there's a lot of people that will put in an Impella and don't really know what to do with it after that,
Right.
Unfortunately. So you have to have the PA catheter to guide the treatment of the patient when they get back to the unit. The cath lab's just half the battle.
Yeah, and I think one of the things we encounter at our facility is a patient who may have gotten intervention and may be waiting for a bed or maybe in standby, and they know that they're in shock, but they don't have that high level of mechanical circulatory support to manage them. They can still call us and say, where are we at? What do I do next? If they don't know the answer to that, and I may, at my end as the APP, be able to shuffle some beds around. I might be able to come up with a solution. But if you're not advocating for all levels of your patient's management at any level of your involvement in their care, you're doing that patient a disservice. So we all have responsibility to generate great outcomes. It's not just what happens in the cath lab. It is every level of their care.
The other thing I was going to mention was the patient you presented was a chronic heart failure patient on Primacor. And one of my big pet peeves actually, when it goes in the chart that a patient has low output heart failure, that's cardiogenic shock.
Yes.
There's no low output heart failure. It's shock or it's not shock.
Yeah,
So,
even if it's Sky Stage A. I've never written Sky Stage A on anybody, but I think that's...
that patient technically is in Sky Stage B shock at home, right?
Yeah.
They're on Primacor already. So just don't use that term. That term is really, it's not descriptive. It doesn't describe how sick your patient is. You need to describe how acutely ill your patient is, and that doesn't do it justice.
Thank you all very much for your time.
Thank you, Andrew.